Good morning everybody, Dr. David Johnson here from the Back Pain Centre, City to Coast Neurosurgery and of course the Functional Movement Training Centre. This video is about the SBS program that was aired on Monday night, Insight. The program was very interesting. It talked a lot about back pain, also touched on knee pain and hip pain, but the interesting parts of the show for us was in relation to back pain. As you know, that's what we're most interested in managing at our centre. And what was most concerning about that program is that the expert panels on the show, many of whom I know, and certainly have read a lot of their research, really appeared just as confused as their patients. Now, if the experts and researchers that are really meant to be leading the industry, the back pain therapeutic industry, are coming across as confused, then how do you think our patients are going to be feeling when they're seeking advice? So let's get into watch the show, and I'll push pause every now and then and talk to you about our take on what is being said during the program.
Hi, I'm Jenny Brocky. Tonight on Insight, are we getting it right when it comes to back, knee and hip surgery? How many knee surgeries have you had over the years altogether?
I'm at 11 now.
Jessica, you had surgery for back pain. Were you given alternatives or was that the only option?
No, that was the only option.
Rhonda, did they work?
Oh, absolutely. Yeah. I was just so glad to have my life back.
Just because somebody says they feel better afterwards, it doesn't mean that they feel better because of the surgery.
You know, we all want the quick fix, and often that's too good to be true.
So we have to rethink the whole idea of treating it surgically.
Jessica, you had surgery for back pain when you were 18. Why?
I did. My L5-S1 disc had herniated.
Just in lay terms, what does that mean?
Basically, the lowest vertebrae in your spine, sort of down there, had herniated, and just the way that it had done that, it was pressing on the nerve root.
So it's like a bulge?
Yes.
What was it like after the surgery?
Well, that procedure was like reasonably minor, like conservative, so they just kind of shaved it back, and the rehab and bouncing back was pretty quick and easy from that. It helped being young as well.
Now, nearly 10 years later, your back pain came back.
It did.
Very strongly.
It did.
Yeah? When you were pregnant. Describe what happened for me and how the pain affected you.
Yeah, so I was about 18 weeks pregnant with my second child, and there was like a defining moment one day getting up where the pain was quite severe, and it sort of was certainly never felt the same again after that.
We've got a scan here of that. What did it show?
Just a nice big bulge there in the same disc, the L5-S1.
What did the operation involve, that you had the second operation?
Yeah, so that one was a fusion, but they
And what, in lay terms, what does that mean?
Basically, they take a little bit of the vertebrae away to get in there. They take the disc away and put like a prosthetic implant in there, use some of your bone to bone graft, put some screws and plates, and then let it all, hopefully the fusion will take the bone graft.
And were you given alternatives or was that the only option?
No, that was the only option. I asked about doing something more conservative beforehand, but it was made very clear that the fusion would always have to take place.
Okay, let's stop it there for a second. So this poor lady is talking about a disc prolapse, which happened when she was very young. She sustained a disc prolapse, she had surgery, and she described shaving down of the disc. So this is really representing very common operation called microdiscectomy surgery. Now we have to understand that this type of surgery is not what the major problem is really focused upon, which is back pain. The first surgery that she's talking about is a nerve operation because the disc prolapse is herniating and pushing onto a nerve, which is causing the neuropathic pain down her legs. And so it's really not about back pain at all. This is a nerve operation, and microdiscectomy surgery, it's not really conjectural at all that patients who have nerve compression, unrelenting and severe pain, possibly with neurological deficits such as weakness or loss of ankle reflexes or loss of sensation, there's no conjecture within the scientific community that if these symptoms are persisting, then the nerve needs to be decompressed. No conjecture at all. The major issue in relation to that particular condition is that no one is explaining to Jessica, the lady's name there, no one is really explaining to her why she sustained the disc prolapse in the first place. Disc prolapses do not just happen with the strike of an unlucky wand, or you're not destined to have a disc prolapse. Disc prolapses occur because of mechanical stress, and in our daily lives, if we are not moving our bodies correctly, there will be mechanical stress on the disc, and in her case the L5S1 disc herniated, and she had an operation to remove that disc herniation, but it doesn't appear that anyone in her treating team has said to her, okay Jessica, you've had this disc prolapse, this is what caused your disc prolapse. We also need to reverse that condition, that movement dysfunction that caused your disc prolapse, in conjunction with the surgery to free the nerve up. And that's the biggest problem in the way that Jessica was cared for there, that she didn't receive a functional movement therapy as part of her overall management. So it's therefore no surprise that she recovered from that very well. She said it was quite simple, the rehabilitation, and she got back to her normal satisfactory level of function. But 10 years later, she had a severe problem again. It just happened to be in association with her pregnancy, and now she's got now the condition of movement dysfunction has reared its ugly head again because it was never actually fixed up right from the beginning, and now she's got a big problem of another herniation, and she's being told by her specialist that she needs to have another operation. And now she's talking about decompression of the nerve again, in conjunction with a back pain operation, which is the fusion component. And we'll see what happens to Jessica as the show goes on. So just they're the most important points in regard to Jessica's opening story there.
Ian Harris, you're an orthopaedic surgeon. When someone comes to you with joint pain, how do you decide whether or not they need surgery?
You look at the severity of the underlying condition, and you look at the severity of their symptoms. So, for instance, if you've got a patient, and I'm imagining James was like this, where he has quite severe symptoms, he has severe pain, or like you were saying, can't sleep at night, difficulty walking, and you've got an x-ray which shows severe arthritis, then you've really got a good case for offering the patient joint replacement. It's a balance of the severity of the condition and the severity of their symptoms, because they don't always go hand in hand.
Okay, so here we have Professor Ian Harris, who's an orthopaedic surgeon, does knee and hip surgery. He doesn't do back surgery, but later he does comment specifically about back pain management, and he's not a back surgeon or a lumbar spine surgeon. And he's sort of contradicting himself here, because he's saying that the decision process relating to whether someone has surgery is linked to the severity of the condition, and the imaging appearances of severe arthritis and the patient's symptoms. And so one would expect that if you have severe symptoms and severe arthritis, then we're going to offer you an operation. And then at the same time, he's saying that they don't go hand in hand. So what he's saying there is that you could have severe arthritis and mild symptoms, which is what we see all the time. Or conversely, you could have very mild arthritis and severe symptoms. And therefore, the whole foundation of that decision-making process is shaky. It's the science that underpins the decision-making process is very shaky if you're contradicting yourself. One moment you're saying you're going to operate on someone with severe symptoms and severe arthritis, and at the same time you're also saying that they don't go hand in hand. So that is immediately a cause for concern for me, and the science that the science that's being used to make these very, very important clinical decisions about surgery is not sound and watertight in its logic, and a professor of orthopaedics has just displayed that by making that comment that really contradicts himself. And let's see what he's got to say a little bit later.
Bastian, a GP is often the first port of call when someone has joint pain. How well do you think GPs are handling things like this?
It's a good question because it's very complicated and very complex. There just is no one-size-fits-all approach, and we have to find very individualized and personalized solutions for our patients. And often that's a trial and error approach, and it often doesn't work straight away. There's no quick fix.
Do you think surgery is being mentioned too soon?
Often it's because it's quite appealing. If you see there is no joint space left on X-ray, you think there is a mechanical solution for that. And we all want the quick fix, and often that's too good to be true.
You've done research on the effectiveness of those operations for osteoarthritis. How do they stack up?
So your probability of getting better is just as good as if you have a pretend operation.
Osteoarthritis affects about 2 million people in Australia. It's one of the most common and disabling chronic conditions, and many people turn to surgery to ease their pain. Hip and knee replacements for osteoarthritis cost our health system over $2 billion a year, more than any other hospital procedure, and we're having more of them. A Victorian study found hip replacements went up 175% from 1994 to 2014, while knee replacements went up 285%. A less invasive procedure, knee arthroscopy, is often done to put off a replacement. It's now the most common orthopaedic surgery. They cost over $100 million a year, with about $10 million in Medicare rebates.
All right, very informative infographics there, talking mainly about hip replacements and knee replacements and arthroscopy procedures. And yes, it is extremely expensive to perform these surgeries, but what the infographic is not telling us is that the massive majority of patients with knee, hip and back pain have not had any surgery at all. I'm not sure of the exact percentages, but just about probably 99% of patients who have these ailments have not actually had any surgery whatsoever. And these patients are out there in the community seeking help, seeking medical attention from their GP, using medications, taking time off work, being reviewed by physical therapists of all sorts of backgrounds. And what is not being displayed in that infographic is how much money that the failing rehabilitation and the failing non-surgical management is costing this country as well. So just keep that in mind, that yes, surgery is very expensive, but the massive proportion of patients who have these symptoms are not actually coming close to a scalpel, and they are still consuming far in excess of the dollar values that are quoted there in regards to surgical intervention. And I'm not saying that the surgery is effective, because often the surgery may not have actually been needed. So that's not my point. My point is not saying that surgery does work, because often the surgery doesn't work, and I'll explain that a little bit later. But don't forget that the patients who are not having surgery, which represent the vast majority, are consuming a lot more money than the patients who are having surgery.
Yet to engage in any kind of specific structured exercise program. Upon assessment, she was very weak in certain areas, and we had also detected some alignment abnormalities. So there was a lot of potential for treatment options. So in the first instance, it was all about reassurance and education around what arthritis was and the benefits that conservative management could have.
And what is the evidence around, exercise and arthritis?
So we've known for quite a long time, as far back as 2004, that there's very strong evidence that a structured exercise program that's tailored and that has a strong emphasis on strengthening in a progressive, graded fashion can have significant improvements in pain, function, quality of life. We've seen that. We've heavily evaluated our program and seen those improvements. In instances where patients need to lose weight, probably 80 to 85% of the patients that have come through my program are detected as being overweight or obese. Giving them the referral to a dietitian and the advice around how to lose that weight in conjunction with exercise can be particularly beneficial. We know that a 5 to 10% reduction in weight loss, for example, in conjunction with an appropriate strength-based program can reduce a patient's pain by 30 to 50%. So that it's been very well proven from high-level studies for quite some time now.
All right, so here we've got a physiotherapist. He's got his Australian Physiotherapy Association polo shirt on, representing the physiotherapy industry. And he's describing an exercise program that is helping patients, which is fantastic. So he's keeping data on his outcomes and is showing that people are improving in their pain, disability, improving in their function without the need for surgery. And that's exactly what we need to do. And it shows that the methodology that he's implementing for his patient with knee pain is working. But you've got to ask this question. All right, this patient for many, many, many years was struggling with pain. What was being delivered to that patient before she stumbled across this fellow? What other physical therapies she received? What was the advice that she received from her GP for years and years before this lady stumbled across the program that's being described? And for her knees to deteriorate to the point where someone is offering her a structural repair, where a surgeon is offering her a structural repair for the deterioration in her knee, implies that for many years the physical rehabilitation that she received was dreadful. And that's really the whole crux of this problem, is the focus of our energy, the focus of our attention should not be about blocking this surgery or reducing the number of surgeries that are done for people. It's about getting people on as early as possible and implementing effective rehabilitation so that they don't break down and even need to consider surgery. But the problem is filtering out all the absolute garbage physical rehabilitation that exists out there, and that's what the challenge should be. It shouldn't really be about talking about surgery at all. The second point is that this fellow is talking about a strengthening program for the patient, and I can guarantee you that the strengthening program is not what improves the musculoskeletal pain, and in specifically when it comes to back pain, strengthening Pilates, core strength, strengthening exercise programs does not work for back pain. Strengthening may be an association with effective rehabilitation, but primarily targeting strengthening does a big fat zero for improving someone's back pain, because strength per se, strength in isolation, does not improve movement proficiency, and it's the movement proficiency that needs to be targeted, which then in turn decreases biomechanical stress on the joint, whether it be a knee or hip or a spinal motion segment, the way that the spine moves. It's that reduction in biomechanical stress on the motion segment that prevents the development of inflammation and biomechanical stress, which leads to inflammation and pain. So it's not the strength. We can be as strong as we like, and if you're moving poorly, you're still going to have back pain. And people who are extremely strong, athletic, triathletes, weightlifters, very, very strong, coal miners, they're very strong, but because they're not moving proficiently, they still have pain. And if your exercise program is focused on strengthening people, then it will fail. If your exercise program is focused on improving movement proficiency, then you will be very successful.
And why do you think that's happening, Lee?
Well, back pain, just looking at the natural history of back pain, 80% of us get back pain at some stage in our life, and 30% probably get more severe back pain each year. So it's the commonest cause that people in general practice would see.
And you're suggesting those are unnecessary cases in a lot of cases?
I wouldn't like to say I'm suggesting it. We just don't have the evidence for to show that fusions are successful just for back pain.
Here's Professor Lee Atkinson. I know Professor Atkinson very well. I worked for Dr. Atkinson for many years in the public sector. Now, what he's saying is quite accurate, that back pain is extremely common. 80 to 90% of lifetime prevalence of back pain is well documented. One of the most common reasons to visit your local doctor is for back pain. The prevalence is increasing. World Health Organization data says that back pain is the number one cause of disability globally. Now, what do all these statistics tell us? It tells us that we are not managing it well. There is absolutely no reason that there should be such a high prevalence. It's not built into our DNA to have back pain. We know from non-industrialized countries that back pain rates and disability rates from back pain and all musculoskeletal pain are a fraction of what the rates are in more developed countries. And what does this tell us? It tells us there's something about our modern lifestyle that actively suppresses movement proficiency. And our modern lifestyle actively suppressing movement proficiency leads to the development of movement dysfunction, and that movement dysfunction leads to mechanical stress and the development of acute back pain, and then poorly managed acute back pain leads to the development of chronic back pain, and then physiological changes associated with chronic back pain lead to this entrenchment of disability, dysfunction, pain, mental health compromise, and the epidemic of economic disease burden and suffering that is placed on the country. It from the outset, without looking and understanding the problem more deeply, it would seem that back pain is completely indiscriminate, that it can affect so many people. It doesn't matter whether they're overweight, underweight, athletic, sedentary, intelligent, not intelligent, whether they're a labourer or a banker. It just doesn't, it seems to be indiscriminate, but it's only indiscriminate if you don't understand what the discriminator is. And what, on a global scale, what's not being understood as the discriminator is movement proficiency. And when you take your eye off the ball, and that ball is movement proficiency, it will look like back pain just affects everybody. And therefore, if you think that back pain affects everybody, whether you're strong or weak, heavy or light, and you apply a treatment principle that says, okay, we've got to get you stronger and we've got to get your weight off, it doesn't make sense, because back pain affects people who aren't heavy. Back pain affects people who aren't strong. So why would you tell someone who you perceive to be weak to get stronger? Or why would you tell someone who you perceive as to be overweight to get lighter, when you know full well that people who are light and people who are strong also get back pain? And it reflects this misunderstanding and taking your eye off the discriminator. And the discriminator is entirely and almost 100% about movement proficiency. And that's why our centre focuses 100% on movement proficiency as our treatment paradigm. And then Dr. Atkinson goes on to talk about spinal fusion. And just remember that spinal fusion, the conjecture as to whether spinal fusion works or not is also misguided. When a surgeon performs a spinal fusion, that does not mandate the development of movement proficiency. And therefore, it's another example of taking your eye off the problem. And the problem is not whether the spinal fusion worked or not, it's whether the spinal fusion was able to allow the patient the potential to regain movement proficiency. Now, if that patient has a spinal fusion and doesn't receive effective rehabilitation, then they will never regain their movement proficiency, and therefore the spinal fusion will have been perceived to fail. It wasn't the fact that the spinal fusion failed, it was the fact that the patient didn't regain their movement proficiency because they went back to doing rehabilitation that never helped them in the first place. The original rehabilitation that the patient had was ineffective, and I call that failed rehab syndrome. And then the patient deteriorated over many years because the mechanical elements of the spine deteriorated with time and ongoing mechanical stress. So the surgeon comes along and says, okay, there's some breakdown in the structure here, let's go do an operation. And then after the operation, the surgeon and the patient's physical therapist are none the wiser. They've taken their eye off the discriminator, which is movement proficiency, and then all of a sudden, a year after surgery, the patient's still disabled, and they're all scratching their heads going, how come the patient's no better? Well, the surgery didn't work. That's not right. That is completely incorrect. The surgery achieved the objectives that it set out to achieve, okay? The surgeon's very happy with the mechanical work that's been done to restructure and stabilise the motion segment. The outcome is still poor because the rehabilitation failed to re-engage the patient in functional movement training and movement proficiency. And that is the crux of the problem. That is I'm 100% sure that is what the failings of the back pain industry is that they're taking their eye off the discriminator, and the discriminator is movement proficiency.
The best evidence we have is that it is not better than a structured non-operative alternative, such as physiotherapy or cognitive behavioural therapy. So that's the best evidence we have, is that it is not better than non-operative.
Timothy, you...
Okay, what's Professor Ian Fraser telling us here? He's being asked to compare surgery and non-surgical management of back pain, and he's saying that the best we can say is that surgery is not better than the non-surgical methods. Okay, so you're comparing surgery and people who have no surgery. What is the difference between those two groups of patients? He's saying that neither is better. Well, let's have a look at that statement. If we actually look at the outcomes of patients who undergo the existing methodology of physical rehabilitation, they are abysmal. Okay, there's been many reviews on core strengthening, Pilates, back schools, cognitive behavioural therapy. In fact, there's not much research at all in cognitive behavioural therapy apart from a few case reports. All of these non-surgical methodologies of trying to help people recover from back pain are train wrecks. Okay, they're just train wrecks. Very, very little evidence to support the rehabilitation methodology out there for people with back pain. Can we make people stronger? Yes, we can. Can we make people more flexible? Yes, we can. Do those methodologies improve on people's back pain? No, they don't. So we are comparing two train wrecks. Now, neither of those train wrecks are really inviting to someone with back pain. I'm not really interested in having a surgery that's going to be a train wreck, and I'm not really interested in having time-consuming, wasteful, futile physical rehabilitation. It's also going to be a train wreck. So why are we actually comparing two train wrecks? Why are we not comparing a management strategy against something that we know works, which is movement proficiency training? The answer to that question is that, and it follows on from my previous little interjection, that on a global scale, surgeons and physical therapists alike are really taking their eye off the discriminator, and the discriminator is whether the patient can re-establish movement proficiency. I could probably guarantee you that if we engaged in surgery and then in conjunction with the surgery got people to move well after the surgery would be very effective. But I also suspect that if we said, look, don't have surgery yet, I know you've got some severe structural breakdown in your spine, but if you are able to move and if you are able to engage in movement therapy, let's do that first. Let's do some functional movement training with qualified movement therapists and see how you are at the end of 2 months. Because I can reassure you that my experience over the last 10 years is that there's many patients that you think may need surgery because of the complete and utter structural breakdown from years of bad rehabilitation. Once you subject them to movement proficiency training, you're amazed at how capable and functional they become, regardless of those structural deficits that you can see on the imaging. So the discriminator again falls back on movement proficiency, not on comparing two train wrecks as they are now, surgery in isolation and failed rehabilitation syndrome in isolation. Hope that makes sense.
Do these operations? What do you think?
I think what we're discussing about here is the evolution of different medical techniques. The ability of the MRI scan to precisely make diagnosis of exactly what's causing pain, as with other techniques, is like we've never seen before. So if one has a joint segment that is extremely painful and you can localise that, then fusion surgery can alleviate that pain.
But we're hearing here that the evidence says it's not effective.
No, that's not.
It's even further than that. And Tim's got an answer to this. I mean, you cannot diagnose pain from an MRI. How can you say the MRI correlates with pain? It doesn't. 30% of people have got abnormal MRIs, but they're not in pain.
Here we go. We've got two specialists in the industry, Tim Steele and Lee Atkinson, just displaying shambolic misunderstanding. If these two people who have had a career of managing back pain can't agree on whether or not an MRI is helpful in managing a patient with back pain, then there's something extremely wrong with the system. Now, what Tim's saying is that MRI is extremely precise at showing us the anatomy of the spine, and that's absolutely true. An MRI is almost like dissecting the body open and looking at the anatomy hands-on. The resolution is incredible for showing structural breakdown. And what Dr. Atkinson is saying is also accurate in the sense that many patients have abnormalities on their MRI. And these are reported as abnormalities, but really they are just referred to as degeneration. If I put, so they're both right in that regard, but they're not understanding the discriminator again. If I put 100 people in an MRI, 60 to 70% of them will have these degenerative changes in their spine that to a spine surgeon, to an unwitting spine surgeon, to a spine surgeon who really is not putting the puzzle pieces together, all of those structural elements could conceivably be the target of a spinal operation or a fusion. And that, of course, is not the case. And there's the mistake and the mixed messages that are being sent to our patients, is that there is a huge difference between the presence of degeneration and the experience of disability and pain. I can have a completely horrible looking MRI and be pain-free and functional, and at the same time I can have a almost normal looking MRI and can be completely disabled and chomping down on my morphine tablets, which is what one of the earlier comments made in the program about the symptoms and the condition not always matching up. And that is exactly right. It boils back down to the fact that these experts in the industry, these so-called experts in the industry, have completely taken their eye off the ball in regards to what the discriminator is. The discriminator is movement proficiency. Now, if that patient who has a fairly degenerate, old, broken down looking spine maintains movement proficiency, we can eliminate the inflammation associated with the degeneration, and we can refer to that as degeneritis as opposed to degeneration, and we can eliminate pain and disability from that patient. If we have a really nice looking MRI, fairly young patient, minimal degenerative changes, and the patient is moving with poor proficiency in their daily life, their activities of daily living, in what I refer to as the sport of life, if they are not engaging in their sport of life, daily activities well, they will be disabled and have a lot of pain. So it's not about it's not just about the structure. It is about the interplay, this critical interplay and balance between structure and function. Ideally, we want to optimize both of those elements that are integral to a healthy working system, the structure of the system and the function of the system. And very often we can optimize the function of the system such that it offsets some minor structural deficits that become apparent on MRI imaging. But we cannot take our eye off the ball and forget about what the discriminating factor is, and that is movement proficiency. Okay, and that's why these guys are all arguing amongst each other, because they're not understanding. None of them are understanding that the most important element in good outcomes is the acquisition of movement proficiency.
Okay, do you accept that pain is a lot more complex than just what you see on an MRI?
Of course it is. It is diagnosing those that are symptomatic, and that is the art and the science of spine surgery. And at this point in time, the diagnosis of trying to ascertain a painful segment is reliant not just on an MRI scan. It's on bone scans, it's on cortisone injections, it's on CAT scans. And if you can see patients with lots of modic end plate changes, which correlate very much with significant pain, then that patient is a suitable candidate for fusion surgery.
So that's a good theory that the old studies aren't applicable anymore, and these days fusion surgery can relieve back pain. And no doubt many of the patients that Tim operates on get better afterwards. But just because somebody says they feel better afterwards, it doesn't mean that they feel better because of the surgery. And those studies have been done and have not shown an advantage.
How many spine fusions would you have done, Timothy?
Of various different natures, probably in the thousands.
How many thousand, roughly?
So probably at 200, 300 a year.
And what's the outcome? No.
Yeah, and what are the outcomes of the operations?
That's a long and involved discussion, but I would say the vast majority of my patients, the vast majority of my patients, of the order of 90%, are happy with their surgery.
I was just trying to say that for the majority of people with non-specific back pain, it's not possible to identify the true cause. So if you have a fracture, or if you have cancer, or you have an infection, you can identify the specific cause.
I would disagree with that in my practice. Like I say, and I must say, I do not see people with non-specific back pain.
Okay, here we've got the first little bit of information from Rochelle Bookbinder, who's a rheumatologist and really has got her wires completely crossed. She's talking about non-specific low back pain here. Now, that whole term, non-specific low back pain, and there's many papers written about non-specific low back pain. What does that mean? What does that say to the patient? You've got back pain. We've got no idea what's causing it. All right, that's what that term means. And Rochelle Bookbinder talks about this a lot. Is that we don't know what's causing your back pain. Now, I personally do not want to go and see a specialist in the back pain industry that's going to turn around and say, you've got non-specific low back pain. I've got no idea what is causing it, so I'm just going to call it non-specific. If we adopt that approach, we are never, ever going to succeed at managing low back pain. That's like saying we don't know what causes headaches, fever, and rigors in Africa, and we'll give you some Panadol, okay? If you come into a clinic in Africa with headache, fever and rigors, the most common cause of that is going to be malaria, and I'm going to treat malaria. Okay, so to say to the world the number one cause of disability is axial low back pain, sorry, it's non-specific, we don't know what's going on. How successful are we going to be at treating that epidemic of condition? And all epidemics, bubonic plague, HIV, influenza, pandemics, right? They have one cause. We don't just shrug our shoulders and say, oh, so that's non-specific, sorry, we'll just give you some Panadol or something that alleviates your symptoms and hope for the best. Because if you don't alleviate the actual cause, if you don't eradicate the driving root cause factor, such as malaria, HIV, a virus, then the pandemic will continue. Okay, so I have absolutely no regard for what Rochelle Bookbinder is saying there, that we don't need to try to find the cause. We do need to try to find the cause, and the cause is very, very simple. The cause is modern society actively suppressing movement proficiency. Think about your modern daily life. Think about what you do. The car you drive, the chairs you sit in, the computers you sit at, the televisions that you watch, the job that you do from 8 o'clock in the morning to 5 o'clock at night. Think about what that lifestyle, that modern lifestyle, does to your muscles, tendons, ligaments and joints, and think about how that changes the way you move your body and what that would do to your musculoskeletal system, and how that would transform normally pain-free, age-related degeneration into painful, disabling degeneritis. Okay. Now, if we're going to eliminate that degeneritis, which is painful and pathological, and transform it back to normal degeneration, we have to eliminate the movement dysfunction that's associated with it. And that is the cause, that is the root cause of our epidemic of back pain, movement dysfunction. the disease of movement dysfunction. And if we're going to win, we have to implement effective movement therapy to eliminate movement dysfunction. Simple.
Most of the people who end up in my service or in my consultation room have exhausted all of these issues and come for a definitive management.
But the failure of
if you would just like to let me finish, I presented my series of cervical fusions for C1, C2 arthritis. For cervical fusion, the success rate of those operations for complete pain relief was more greater than 95%. So that was, and we have published that paper, and that is of the same order of magnitude of betterment as total hip replacement.
Okay,
but without a control group, you can't tell whether that improvement, and it might be improved, is due to the actual effect of the surgery, the placebo response, or regression to the mean. It's been shown for knee arthroscopy that 97% of the improvement that people have after arthroscopy is those non-specific effects. It's not the specific effect of the surgery.
That's it.
And if you think that you have better results than the placebo-controlled trials, then I challenge you to do a placebo-controlled trial.
Okay, Simone, you've
Okay,
had
so
surgery
here's
on both
Michelle,
your upper and lower back.
The
Why?
bookbinder again talking about
my lumbar,
engaging in trials for surgical
laminectomy
outcomes, and
at
that is of course
L4-5
necessary
due to
And
in
in
science
lay terms
to
is bulging
maintain
disc?
a high
bulging disc.
a standard
It was
of care.
done
And
due to
if we
sciatica pain down my leg,
engaged in those
weakness,
trials that compared
and then 4
surgery
years ago,
to
cervical
non-surgical
fusion
management,
at C5,
and we
6,
left out
which is in the
movement
neck.
deficiency, then I
Also
would not
due to
expect
weakening in
the
my
outcomes from
arms.
surgery to be any
So were you in a lot of pain as
to
well?
be significantly better
What was the
debilitating.
or
pain
worse.
like?
They'd be just
I
the
remember
same
having to
because
sit in the bottom of the
neither
shower
of
'cause I couldn't stand.
the arms of the trial
It was just
Was this leg pain or back
focusing on movement
I had
proficiency,
back
so you
pain,
would
but
not
the
expect
sciatica
any
was down
difference.
my
And
leg,
that's
so therefore
exactly
I
what
couldn't
Ian
stand.
Fraser said earlier.
Had you
That
tried
there's no
other
difference
things
between
with your back?
non-surgical and
Everything.
surgical treatment
Imaging.
because
I
neither of
remember
the
being
arms of the
traction,
trial
physio,
are actually
chiros,
focusing on movement
osteos.
proficiency. They're just
And how
talking
did
about
that go? How did
existing
physio
treatment
go, for
methodologies
example?
with
The other
rehab
things.
and existing
They
treatment
went well to a
methodologies with
point
surgery. So why would you expect
where
any
my
difference?
physio, I remember once saying, I can't
But
do any more for
if
you, go back to your
look
surgeon,
at
see if you'll
how we
operate on.
rehabilitate people,
So it was a back
looking
and
at the
forth.
studies that are
Timothy, can
reviewing
you describe the
non-surgical
procedures that you
rehabilitation for
do
back
in your
pain,
surgery for us? You've got a model with you, I think, to
we can
show.
subject someone to a
What
structured
operations do you
rehabilitation
actually
program
do?
with conventional methodologies
In
of core
surgery or in
strengthening,
spine surgery, there are only two operations
education,
we do.
Pilates,
One is decompress nerves, and the
gym-based
other one is
programs,
fuse bones together.
and
Now, in a majority of
that
cases for spine
structured
fusion,
rehabilitation
decompressing and
is
removing
not
portions
found
of
to
the
be
bone
any better
requires some sort
than
of
going for a
implant to be
walk
put
around the
in.
block.
And that can
Okay.
either be screws
So
placed
what does that tell us?
posteriorly
Does that
or
tell us that going for a walk around the
in
block is
form of an
amazing
anterior
at
fusion?
restoring
But
back
the
pain?
objective
Of course it
is to
doesn't. If
stabilise
people
the
had
bones together
terrible
to
disabling
allow
back
bone
pain
to
and
grow
went
across
for
it,
a walk
achieving
around the
mid
block to
bone
get better,
fusion.
that's what they do.
Okay, Simone, how
But
did your
what it
surgery
tells
turn
us
out?
is that these structured,
I know today I
expensive,
still have to be careful
prolonged,
what I do,
existing
gardening,
rehab
ironing, that sort of
methodologies
thing, but overall,
is no better than
Very
going for a
happy
walk around the block.
with both
And that
surgery
just
outcomes.
basically tells us
Jessica,
that
how did your
the
back
rehab
operations work out?
is next to useless as
Not
well.
ideal for me.
Okay.
And
And it makes sense
I had
because
the fusion
existing
done, similar to what you've
rehabilitation
described.
methodologies
And in my
do
case,
not
3
focus
weeks
on movement
post-surgery,
proficiency.
we found that the
So
implant
going
had
for a walk
moved.
around the block,
So I had to have
doing a structured, expensive, prolonged
a follow-up
rehabilitation
surgery,
program,
a revision,
and then doing surgery
and,
are
in
all
that
really
they
as bad as each
adjusted
other
the positioning,
if you leave out
and a
the
bone
movement
spur had
proficiency
formed, so they
training.
treated that,
Okay. And that's
did some
why
further
the statistics are so
laminectomy, and so on.
baffling to these researchers and
So
so
following all
confusing
of
that they can't get their
I had then had
their
3
act together.
surgeries on the same
And
location.
if the
And
experts
was
can't
still
get their act together,
experiencing the same
the
level
patients are
of
certainly
nerve
going
pain, neuropathic pain.
continue to be lost,
at
and the
this
prevalence
point,
of back
I have
pain is going
like
to
scar
continue
tissue
to
that's
increase
compressing the
as
nerve
our
root.
data is showing us.
I have inflammation, and I'm no longer under the care of my surgeon. I've just been referred to a pain specialist for that ongoing process.
Where has all this left you? What can you do? What can't you do?
So I still take a great deal of medication daily, which is not ideal. I am less than functional. So all I want is to be functional, like be able to unload the dishwasher, push my kids on the swing, and I'm not there yet.
And you can't do that.
Now, this is really upsetting that this poor lady has had her fusion operation, and then there's obviously been a complication with the fusion operation, and she said that the implant moved and had to be readjusted, and this no doubt represents a surgical complication. And of course, when you have a surgical complication, that may well lead to true failed surgery syndrome. But let me just point out that when we engage in spinal fusion surgery, the information that is provided to patients about the risks and potential complications of the surgery is huge. And patients will receive reams of information booklets. They'll have lengthy consultations with their surgeons before they proceed to surgery. And the actual intraoperative and early post-operative complication rate from surgery is very low, probably in the order of 5% or less. So that means that 95% of surgeries that are conducted on the spine actually go to plan. They carry out the job that was, they carry out the task that was desired in the planning stages of that surgery. So the actual complication rate from surgery is very low. Now that does not mean that 6 months after the surgery that the patient is going to be free of pain. So it's not uncommon, and I see many patients that have had surgery elsewhere that have had a perfect operation, and I openly tell the patient that their surgeon has done a wonderful job in terms of the structural repair, the nuts and bolts that are put into the spine that Dr. Tim Steele was talking about there. That's really the easy part of management. Regardless of the surgery going fantastically 95% of the time, and Jessica's one of the 5% that are unlucky that had a complication, the 95% of people that have had a perfectly performed surgery may still be troubled with pain and disability after their perfect surgery. The reason being, surgery does not cut out pain. Surgery does not mandate the return of movement proficiency. And the surgery should only be performed with the understanding that it is going to give the potential, it's going to give the patient the potential to regain their movement proficiency. When the patient regains their movement proficiency after surgery, the surgery will be successful. 5% of patients may encounter a surgical complication, such as a screw misplacement, such as an implant migration, such as infection, such as nerve injury during the surgery, and that, of course, is a completely different cohort of patient that may have ongoing pain because of those intraoperative or early post-operative complications. But that is by far the minority of patients that are unhappy. The patients that I see every single day have had operations that have just been performed to the key, to the dot, to the letter of the plan, but unfortunately are still unhappy. And the reason they're unhappy and the reason why they've come to see me is because they want to engage in movement therapy, which has been left out of their whole management formula by their previous surgeon. Okay, I hope that makes sense.
Carly, you're on a wait list to have back surgery at the moment.
See it for a consult? Yeah, just not so much surgery, but I'm trying to find out what's really going on. In 2016, I got another bulging disc and it's compressed a nerve, and I've got numbness in my right leg since.
If surgery is offered to you, if a spinal fusion was offered to you, would you take it up, do you think?
I don't think that's something that I would enter into lightly. I think that's something that we would need to discuss. Like everyone has said, and it's not necessarily about surgery, it's about where to next and what my options might be. Answers. I think everyone wants answers.
The latest figures do show a massive increase in spinal fusions. Why? What's happening?
Well, one thing that we found in our study was that the increase was largely in the private sector. So the study that Lee was referring to over a 10-year period showed over 150% increase in spine fusion in the private sector. And in the public sector along the same time, the increase was 2%. And now you're more than 10 times more likely to have a spine fusion in the private sector than the public sector.
I don't think looking at the operations being performed in private versus public is overly helpful. I think surgery that's performed privately is always going to be different to surgeries being performed publicly. There's a very different cohort of patients that seek out private care versus patients that front up to an emergency department in a public hospital that need surgery for whatever it may be. For example, acute conditions, acute life-threatening conditions, trauma. They're always going to take precedence in public hospitals versus the surgeries that are performed in private hospitals with the patients paying and private health and having private health insurance. It's not a very helpful discussion. It also reflects the increasing prevalence of back pain. It also reflects the increasing failure of rehabilitation, with physical therapists and GPs really being lost as to what to do. And I can assure you that any patient that sees a surgeon will always go through a filtering process whereby, as a surgeon, we try, or at least I could speak for myself, but the general teaching in our training is to do everything we can to avoid surgery, because if anyone knows how risky an operation is, it's going to be surgeons. Surgeons are the only people that really can make that risk-benefit analysis as to whether the benefits of surgery outweigh the risks. No one else can do that. No pain physician, no GP, no rheumatologist can make that clinical decision as to whether the benefits of surgery outweigh risks. And I spend most of my days explaining to people why surgery can't help them, it's really not helpful to be talking about whether private spine surgery is performed much more than public spine surgery. It just paints surgeons in a bad light, and it's inaccurate, and it's reflective of, again, the industry's failings, as the industry's systemic failings. So that's my take on that particular point that's being raised there by Professor Ian Harris. Unhelpful.
Compared, say, to knee replacement, which is 2 or 3 times more likely in the private sector.
Jim, why do you think there's been this big increase?
One thing we are seeing, and certainly I'm seeing now, or certainly I think all of us are seeing, is we're all living longer and we're living better. Barry here had surgery about a month ago. He's 82.
In my particular case at 82, who trains every day, as far as looking after myself, the worst 5 months of my life until I saw Tim. All these other alternate medicines or treatments and such, they're all right for an hour or so, but to get permanent relief, you've got to have surgery. Otherwise, the only other alternative, to try all those other pain relief, physio, all the other treatments, Indians with beards and turbans and all that, all it is spending money.
Now, here we have someone who's 80 odd and is probably talking more sense than anybody in the room. He's talking about the futility of the existing rehabilitation that he participated in. He's talked about spending money, wasting time, and he also mentioned the fact that he's now exercising every day. Now, he has unwittingly implemented what I call the tandem approach to fixing his problem. He's engaged in a optimization of the most critical elements of having a healthy, pain-free, robust spine, and that is the interplay between structure and function. Okay, so he obviously had some deficits in his structure, and he's had that fixed up, but he's also restored the functional proficiency of his spine. So that interplay that he now has allows him to maintain a healthy, pain-free spine that he's satisfied with. Okay, so he has fixed up, he's optimized the interplay between his own structure and his own functional requirements. Structure function is absolutely critical, and we need to be thinking about what we need to do for structural optimization and what we need to do for functional optimization. Do we need to fix structure? That is the decision for the surgeon. If the surgeon just fixes structure and ignores function, the patient and the surgeon are going to be disappointed. If we try to improve function and we have structural elements that are too far advanced and too far compromised or unstable, then the functional movement therapist trying to restore function is also going to be disappointed, and the patient's going to be disappointed, because you cannot maintain a high level of movement proficiency in the presence of structural elements that are too far gone. So therefore, it makes sense to restore the structure, and that is our tandem approach, is repairing structure when it needs to be, and implementing a functional repair. The other element associated with the tandem approach is controlling symptoms and eliminating cause. Okay, so there's two sides to the tandem approach: control symptoms, eliminate cause, optimize structure, optimize function, and you'll have a lot of happy patients.
Okay, Rochelle, you're a rheumatologist and you're doing research on patient and surgeon attitudes to back pain. What have you found?
Well, we've found lots of different interesting things. One of the things that we've really identified is that patients aren't being educated, they're not being explained the latest evidence, and they're often getting incorrect advice, and it's time that we all sort of work together so that patients aren't confused and that we know what the right treatment is.
Now, you're concerned we're doing too many MRIs and scans, aren't you? And I know the argument about, I think most people know the argument about the cost of that, but you've got other concerns as well. What are they?
They show up lots and lots of abnormalities that may or may not be the cause of the problem, and then patients get worried, their doctors get worried, and it often leads to downstream harm like further tests and unwanted and unnecessary treatments. And the biggest thing that I am concerned about is it can actually do harm, and we haven't talked a lot about harm today, but there's risks in even just doing an arthroscopy, even in a young person. The risks can vary between 1% and 5%. People can die, and there's mounting evidence that it might actually, the more tissue that you take, the greater the risk of needing a joint replacement earlier, particularly in older people.
So here's Rochelle talking again and really displaying her ignorance on the problem. She's talking about imaging, and she's concerned about people over-imaging the spine. I just don't understand why people are worried about over-imaging. Number one, an MRI scan has no radiation associated with it. It's a very safe test. As surgeons, we want to look at the structure of the region of the body that we're specialised to deal with. We don't want to miss rare causes of back pain, and I can promise you that there are many cases where patients have presented to me with a long-standing history of pain and suffering, and imaging hasn't been performed, and as soon as that imaging is performed, it's like the penny dropped. Why the heck wasn't this done a year ago? It's not a problem with the imaging, it's a problem with the person interpreting the imaging. And if you're so concerned about imaging being misused, then what we should be doing is restricting the request for imaging to people who are qualified to action the results of it. And maybe rheumatologists shouldn't be allowed to order MRIs, maybe of the back. Maybe GPs shouldn't be allowed to organise MRIs because they don't have the skills to then interpret those MRIs in the context of that patient. Physiotherapists I know are very bad at interpreting an MRI image. They can certainly read a report, and Rochelle does have a point that the report highlights a lot of things associated with the spine, and 99% of the report is not actually relevant to that patient's presentation. And so if you're only looking at the report and not looking at the imaging and not treating that patient in the context of their overall clinical presentation, you should not be ordering an MRI. Okay, that's really important. But if you have the qualifications and the skills to look at the MRI images, put the report aside, look at the MRI images, correlate those images with your patient's clinical presentation, and then decide about the interaction between the structure that you're seeing on the images and the function of that patient, then an MRI is absolutely invaluable and must be performed for patients who are coming to see you with persistent pain symptoms.
James, how much do you two think you've spent?
I have been very lucky, and I'm so thankful of the public health system to get my knee joints that I haven't been out of pocket. But just chasing up, and we see chiropractors and massage therapists and stuff. And
we both have a fortnightly massage just to try and help alleviate some of the...
With the therapist, yeah.
Yeah, with the therapist. And then also physio. I do bouts of physio, so I might do 2 months at a time.
So can you work out roughly how much you would spend on all that?
Oh, physios. Probably a lot of that is physios and stuff, so probably around...
300-400 a month, yeah? At least more?
Yeah, probably around 300 a month.
And do you have private health insurance?
We both have it for extras cover, so for some physio.
Is it cheaper for people to have surgery for themselves, cheaper than it is to, take on something else?
Yeah, there's a problem with the funding in that the funding model that we have at the moment funds surgery. It doesn't fund exercise and weight loss.
Given the experiences you've all had, what would you like to see change in the health system?
I'd say early access. Yeah, earlier recognition or avenues or access.
Knowing where to find things.
Yeah, knowing where to find things.
Who else has thoughts about what they'd like to change?
I think the education from the GP level that these non-surgical approaches are available. I certainly didn't know. And I've lived with this for 40 years.
Yeah. Lived with what?
With osteoarthritis, so I've got it.
Thank you so much for joining us. Thank you to all of you for joining us. It's been a really interesting discussion, and that is all we have time for here. But let's keep talking on Twitter and on Facebook. Good night.
Okay, that's the end of the program. Thank you so much for listening and watching. I hope you found it useful. I found the show very helpful in highlighting some major flaws in the back pain therapy industry. It really crystallised where there's a lot of misunderstanding, poor information that's being put forward to patients. Even the experts in the country, you can't agree upon what to do, and that really is a shambolic state of affairs when the experts who are supposed to be leading the way don't know what's going on and can't interpret the data or are misinterpreting the research data. The trials are not being set up well. No one is focusing on movement proficiency as a whole. There are individual pockets of people, certainly people that I know of, who have communicated with me and who are on the same page when it comes to understanding the imperative requirement of movement proficiency. And we collect data on all of our patients that participate in functional movement training. We receive the cohort of patients that have broken down, that have been everywhere, that have been on the merry-go-round of pain management, back pain, rehab programs elsewhere, that just come to us saying we're no better. We've spent thousands. We've been suffering for years and years, like 10 to 15 to 20 years is not uncommon, and they're lost in the wilderness. And as soon as we start implementing the most important discriminator of all, which is movement proficiency, very occasionally we need to throw in there a structural repair because they've been ignored for so long. The structural elements have just been broken down too far, and of course that needs to be fixed up. Just like if your car's got a flat tire, you need to fix that up if you're going to continue on your journey. But that's really a rarity. The vast majority of patients have not had any surgery, and they just need a simple, effective, movement proficiency focused rehabilitation. That is really not widely available. A functional movement training centre is really leading the way in terms of movement training with the NeuroHab program. So my final words are that we do offer educational clinics, and we do offer public Q&A nights whereby patients and GPs and anyone, physical therapists, are welcome to come along and have Q&A sessions with us to talk about back pain and what's required to surmount this growing epidemic of disease. So thanks very much. Talk to you again. Sorry it was a long one. Good night.